So this is my disclosure. So food allergies are quite common, and actually their prevalence is increasing, and it's up to 4% of the population now. It may be defined as mild to severe symptoms occurring after food ingestion, and at the extreme, it could be anaphylaxis reaction with severe systemic hypersensitivity reaction, including life-threatening airway, breathing, or circulatory problems. These manifestations are usually associated with skin and mucosal changes, so we can have some urticaria or some digestive symptoms. These are immune acute reaction, and they are mediated through IgE. Besides these food allergies, we have the eosinophilic esophagitis, which is an emerging disease and which might be related to food allergies. So today I will really focus my talk actually on eosinophilic esophagitis and its relationship with the food allergies. So why focusing on eosinophilic esophagitis? Because this is an emerging disease, and this is now the leading cause of dysphagia and food impaction in children and in young adults. This disease was firstly described actually in the 70s, but the first description as a clinical pathological entity was made in 1993. And this is an inflammatory condition of the esophagus characterized by an eosinophil cells infiltration in the esophageal mucosa. Currently, we have really an increase in the number of identified patients with EOE. So it might be due to a better recognition of the disease, but also to a true increase of prevalence and incidence. And this was shown in different studies. And for example, in this study performed in Switzerland, you can see that for a nearly constant number of upper GI endoscopy, there is a true increase of incidence of eosinophilic esophagitis, especially in males, as you can see here, but also in females. So eosinophilic esophagitis is really increasing, at least in Western countries and in North America. So how can we define this disease? So this is a chronic, local, immune-mediated esophageal disease. And to make the diagnosis, you need to have some clinical symptoms. So these symptoms are related to esophageal dysfunction. On endoscopy, you can have some very typical feature. And here you have the rings. There is some furrows. You can have some white exudate, or you can have also some stenosis. But the endoscopy can be also completely normal. And the diagnosis, the final diagnosis, is made by histology. There is an eosinophil predominant inflammation, and we need at least 15 EO cells per eye-power field to make the diagnosis of eosinophilic esophagitis. Regarding the pathophysiology of the disease, so this is an antigen-mediated Th2 inflammatory response characterized by an eosinophilic inflammation, an alteration of the barrier integrity, and there is also some remodeling and fibrosis of the esophageal wall. Now we know that there is an interplay between the environmental factors and the genetic susceptibility. We have also a cooperative roles between activated eosinophils, mast cell, and cytokine, and all of them actually are mediated by allergic sensitization to multiple foods. So if we want to summarize the pathophysiology of EOE in a figure, so we have the allergens, and the allergen interact with the esophageal mucosa. And they will elicit production of pro-atopy cytokine and also a production of TSLP. This will lead to actually an activation of T cells. So this is an activation of T regulatory cells, but also Th2 cells. And these cells will secrete some cytokine, EL5, EL13, and TGF-beta. EL5 and EL13 are promoting eosinophilic inflammation, and this promotion is done through eotaxin 3, which is a very powerful chemoattractant for eosinophil cells. EL13 and TGF-beta, which is secreted not only by the T cells but also by the mast cell and the eosinophils, are responsible of remodeling and alteration of the barrier integrity. And actually, this alteration of the barrier integrity will facilitate the penetration of the allergen inside the esophageal mucosa. Besides the roles of the allergens, there is also more and more evidence now to have some role of dysbiosis in the occurrence of eosinophilic esophagitis. And the patient with eosinophilic esophagitis have more esophageal dysbiosis compared to controls. Finally, gastroesophageal reflux disease might also play a role because you know that GERD is responsible of an alteration of barrier integrity, and again, this alteration will facilitate the penetration of the allergens inside the esophageal mucosa. So now we have more and more evidence to recognize EOE as an allergy or as a special form of food allergy. So what are these evidence? First of all, there is some models in mice. And actually, when these mice are sensitized with oral ovalbumin, peanut, or inhaled aspergillus, dust mite antigen, we may see some esophageal eosinophilia. And this esophageal eosinophilia is dependent of EL5, EL13, and eotaxin 3. Beside this data in animals, we have also some evidence in humans to support a role of food allergy or of allergy in EOE. And indeed, there is a high number of concomitant atopic disorders in patients with EOE. We can encounter rhinitis, asthma, eczema, and actually the patient with EOE has a personal history of atopy in 50 to 60% of the case. It is really important to note that this history of allergy might be really different regarding the age of the patient. Indeed, in young children, there is more frequently food sensitization and allergic response, while in older children and adults, we have more aeroallergen allergies. Finally, the last evidence to support a role of food allergy in EOE is the success of the dietary antigen elimination. And when you eliminate this antigen, there is a remission of EOE. So the remission is observed when you use amino acid-based formula, but also when you use some empiric diet, and for example, the 6-food elimination diet. We will see later more data regarding this diet, but when we use this empiric diet, you have a remission of EOE in more than 50% of the patient. And interestingly, when you perform a reintroduction of this food, you have a recurrence of eosinophilia. So we have some evidence to support the role of the food in the occurrence of esophageal eosinophilia. Based on this data, recently the European guidelines on EOE stated that EOE was a distinct form of food allergy. The expert also recognized that IgE-mediated food allergies were common in EOE patients, and there were sensitization to aeroallergen or to food allergen. So based on this data, we can wonder what could be the role of the allergy testing in patients with eosinophilic esophagitis. So to test for food allergy, we have different types of tests. And we have some tests we are focused on the immediate food hypersensitivity, which is actually based on a food-specific IgE reaction. And this immediate hypersensitivity is highly reproducible with a clinical reaction following the injection of the food. So to test this immediate hypersensitivity, we can use either the serum IgE which is just a blood sample, or the skin prick test. So the skin prick test consists of injected in the skin, the allergen, and to search for a reaction, which is usually a swollen or a red area. If we want to test for the delayed food hypersensitivity, which is a non-IgE cell-mediated food reaction, we can use the atopy patch test. And this test actually consists of applying some allergens on the skin. So usually this is applied on the back. And we will search for a reaction. And usually the reaction will occur in few hours or few days. So this is the different tests available for food allergies. So what about the results of this test in patients with EOE? So first of all, the IgE testing. So it was shown that there is IgE against egg, soy, peanut, very commonly in adult patients with EOE. However, it's important to note that there is a lot of polysensitization to food and aeroallergens. And it was demonstrated, for example, in this study from Netherlands. So they included 76 patients with EOE. Among these patients, there were at least one atopic disease in 84%. And all these patients were tested for specific IgE antibodies against 112 food and aeroallergens. And they also observed that 74% of the patients had a sensitization against aeroallergen. And beside that, a cross-reactivity between birch pollen and food allergen was observed in 39% of patients. So that means that this polysensitization seems to be quite frequent, actually, in adult patients with EOE. So, unfortunately, we have other data which are less encouraging for the role of IgE. And especially, there is some food-specific IgE in subjects without any symptoms. So this might limit the value of this test. Further, when you look at patients with EOE, the level of food-specific IgE is modestly increased compared to patients with food anaphylaxis. And finally, the elevated serum food-specific IgE does not necessarily predict the EOE triggering foods. So IgE might have a role in EOE, but this role seems to be limited, and actually this is supported by the results of clinical trial testing anti-IgE therapy, and this anti-IgE therapy is not effective to reduce symptoms in eosinophilia in patients with EOE. So what about the other tests? And for example, the skin prick test. So in patients with EOE, there is at least one positive skin prick test to food in 77% of children and 50% of adults with EOE. And the test is more likely positive if fresh food are used. However, when you look at the positive predictive value of this test, you can see that it's really variable. It's ranged from 26 to 96%. It might be a little bit better if you look at the negative predictive value, with a negative predictive value ranging from 79% to 90% for egg, wheat, and soy, but only 30% for milk. So again, the skin prick test seem to have a limited value in patients with EOE. What about the atopy patch test? Again, the positive predictive value is really variable from 12% to 86%. The negative predictive value is quite good, but for the milk, this negative predictive value is only 31%. Further, the atopy patch test has different limitations. The performance of the test is not standardized, and we might have a subjective interpretation. So you can see that the results of this test are more or less disappointed. However, some authors try to build some diet based on the results of the test. And when you use this elimination diet based on the results of the test, there is an histologic remission in 45% of patients, and is slightly better in children than in adults. So there is kind of a response. However, this specific diet, which target the food identified by the allergy testing, does not perform better than an empiric diet. And it was shown actually in this very nice large study. Yes, it's a retrospective study, but they look at the different diets performed in this very large cohort of patients. And when you look at the histologic response in patients who had a diet based on allergy testing, and in patients who had a diet based on the 6-food elimination diet, actually the response rate is exactly the same. Yes, this is a retrospective study. However, it seemed that the targeted diet does not perform better than the empiric diet. So based on these different results, the European guidelines on EOE stated that the utility of allergy tests in the identification of food triggers of EOE is constantly low in adults and variable in children. Moreover, the serum IgE is usually associated or is frequently associated with cross-reactivity, and serum IgE can be positive in patients without symptoms. So the diagnostic accuracy of these different allergy tests, and especially of the skin allergy test, seems to be insufficient in patients with EOE. So is there a way to do better and to improve this allergy testing in EOE patients? Recently, the group of Amsterdam proposed to perform some esophageal prick tests, and they performed a feasibility study in 8 EOE patients and 3 LC controls. And they injected into the esophageal mucosa some allergen extract. So they use wheat, milk, soy, and also 3 allergens based actually on patient history. They use histamine as positive control and saline as negative control. And so they perform the injection during the endoscopy, and they record for local reaction for 20 minutes. A second endoscopy was performed 24 hours later. And so in this patient, they observed an acute reaction in 5 patients. So there were luminal obstruction and blanching. And in 2 patients, they observed a delayed reaction, so at 24 hours, with this erythematous wheal. 1 patient actually had 1 acute reaction and 1 delayed reaction, but it was not for the same allergen. So this esophageal prick test seems to be feasible. However, we need data to know if this test is really useful in patients with EOE, and especially to know if this test might help us to choose the best diet for the patient. So this brings us to the diet to treat EOE. So we can use either elemental diet or elimination diet. So it could be an empiric elimination diet or a test-directed elimination diet. So I already told you that when you based diet on the results of the allergy test, this is not good. So I will not say anything more about that. And I will try to show you if the Irish diet is good for patients with EOE or not. So first of all, the elemental diet. So this is an amino acid-based formula, and it allows the elimination of all potential triggers. So it was firstly tested in children with refractory eosinophilic inflammation. The diet was offered for 6 weeks, and there were a complete remission in 8 patients and a symptom improvement in the 2 other patients. So all these children have a response with this kind of diet. What about the results in adults? And again, a study performed by the Dutch group. And so they offer the diet to 34% of the patients. However, you can see that 21% of the patients did not start the diet because of the test. So 21 patients started the diet, The diet was completed by 17 patients, 12 were responders and 4 partial responders. So if you take into account actually the response based on the number of patients who started the diet, the response rate is 76%. So this elemental diet is working for EOE. The overall efficacy is more or less greater than 90%. However, there is a lot of limitation for this diet. First of all, the cost is quite high and it might be not covered by health insurance. The taste is really poor, and when you use this kind of diet, you induce major lifestyle modification. And even if this is just for a short while, the adherence to this kind of diet might be very, very challenging, especially in adult patients. So, what about using some empiric elimination diet? So the first empiric elimination diet was the 6-food elimination diet. So it was proposed first in children, and milk, soy, egg, wheat, peanut, tree nut, fish, and shellfish were eliminated from the diet. So I will show you the results of one study in adults, 50 patients, one single center, and after 6 weeks, there was a symptomatic response in 94% of the patients, and an endoscopic and histological response in 78% of the patients. So after this response, the author performed a sequential food reintroduction, and after each food which is reintroduced, the patient had an endoscopy 2 weeks later. And based on this test of reintroduction, wheat and milk were more likely associated with EOE. When the author looked at the results of the skin prick test, actually this test predicted only 13% of food associated with EOE. So again, a very limited value of the skin prick test, but when you perform this empiric diet, it works. The results was confirmed in another study performed by the Spanish group, and so the response rate was 73%. And interestingly, this group showed that there was 1 food trigger in 1/3 of the patient, 2 food triggers in 1/3, and at least 3 food triggers in 1/3 of patients. And based on the reintroduction test, the most common food allergen were again milk, wheat, egg, and legumes. So based on these results, the Spanish group proposed to use a 4-food elimination diet. So they eliminated from the diet milk, wheat, egg, and legumes, and they performed a multi-center study in adults for 6 weeks, and a remission was observed in more than half of the patients. Again, the most frequent food trigger was milk, and for the patient who did not respond, they were offered a 6-food elimination diet. And if you look at the overall efficacy, it's 72%. So quite interesting response in this patient. This results of 4-food elimination diet was also confirmed in a cohort of children, almost the same diet, almost the same results. And again, the most frequent food trigger is milk, followed by egg and wheat. So it seems that this 4-food elimination diet is quite interesting in patients with EOE. It's less restrictive than the 6-food elimination diet. It could be efficient in more than half of patients with EOE. And one advantage is that you need less repeated endoscopy for the food reintroduction protocol. So it might be an interesting option in patients with EOE. And finally, the Spanish group proposed to go even further and to perform just a 2-food elimination diet. So they proposed to eliminate all animal milk and gluten-containing cereals, and they presented their results last year at UEGW. And they observed a remission in 40% of patients, so they included children and adults. And for the patient who did not respond, they offer a 4-food elimination diet and eventually a 6-food elimination diet. And again, when you look at this step-up empiric elimination diet protocol, the overall remission is 65%. So this step-up approach seems to be quite interesting in patients with EOE. So to conclude, we have some evidences to support a role of food allergy in EOE. The most frequent food triggers are milk and wheat. I show you that there was a really limited value of allergies testing so far. However, the esophageal prick test might be helpful, but of course we need really more data to support that. And the elimination diet is a very interesting option in patients with EOE. So it seems that the empiric diet is interesting in this patient, but it remains to determine if we have to perform a step-down protocol, so starting by 6-food elimination diet, or a step-up protocol, starting by a 2-food elimination diet. And to conclude, so if you have EOE, you can probably eat without any problems the Irish stew. For the Irish breakfast, you have to forget about it because of the egg and the beans. And I'm sorry, but the beer is probably not really good for you neither. I thank you for your attention. And I just would like to remind you that we will have a meeting on GERD in Lyon in November, and I will be very happy to welcome you in this meeting. Thank you for your attention.